Hi everybody, it's lesson 9 and we're going to talk this week about muscular dystrophy. This is a topic that when I went to the literature to search for information about muscular dystrophy, there's not a ton of stuff in OT literature about muscular dystrophy. I think that we do see these kids sometimes for certain skills that they need assistance with, but a lot of times these kids are seen, especially certified people, to do seating and positioning and things like that largely, and not always having issues with cognition or fine motor skills or those things, but more the bigger mobility issues. And so I think if you go to the literature and look for information, you're not going to see as much on muscular dystrophy as you do for some other types of diseases that people would have. But it's an important topic, and also I'm really excited because this is a topic that was especially important to a couple people in our past graduating classes, and so they actually became connected to the MDA and started doing the camp for muscular dystrophy. So one of the things I've put on for you this week as your assignment is for you to go and explore the MDA camp information and see if that's something that you would be really interested in doing. We do have, they have contacted me and asked for people to be volunteers, and I have asked some of the graduates from before who have done the camp to send me some kind of little narrative thing about the camp or a video or something so that you can learn more about it. And they said they would, but then they get busy working. So if that does happen, I'll make sure to get that forwarded to you. So we're going to go through some different information about muscular dystrophy. One of the things that is important for you to know about this group of diseases is that it is a group of diseases. There are actually 9 different types of muscular dystrophy, and all of the types of muscular dystrophy do basically cause the same issues, but then there's quite a bit of variance between them. So in a minute we're going to talk through that. But in general, if you have muscular dystrophy, you have this progressive weakness, and you usually lose muscle mass or muscle atrophy. As I said, there's 9 different types, and in muscular dystrophy, every type has, of course, a different genetic component, but essentially, in general, for the 9 types, what happens is that some kind of mutation in the gene interferes with the production of proteins, which then makes the muscle not form correctly. And so there's a lot of differences. I'm not going to expect you to go into the really significant differences between the different types of muscular dystrophy. I just want you to be aware of, in general, the different types of, I am going to go through the types and give you some hints about specific things that we're going to look at, but you don't need to go through and know all the gene mutations and all that. That's not something that you'll need to know. One thing it is important to know with muscular dystrophy, there is no cure, and generally muscular dystrophy is a degenerative type of disease. And so our goal is to help them, whether it's a child or an adult, if they live to adulthood, to manage their symptoms, slow down the course of the disease, which isn't our role, but more the medical role. And where our role is primarily to help them maintain the function so that they can go about their life and do what they need to do. One of the things, if you're not familiar with Shriners, a lot of kids that have muscular dystrophy are seen at Shriners, and if you're not familiar with Shriners, it's a fantastic organization, and they, much like St. Jude's, actually don't charge for their services for the most part. You apply to be able to get services at Shriners, and then they actually, not only does it not cost you to go there, but they also have different services. Like they would have somebody from Shriners actually travel with you to your appointment if you had to go to St. Louis, for instance. I have had a student in the past who had, her child had Shriners services, and really great services. And so those are kinds of things that for you to check into whenever you, as a clinician or as a pre-clinician, are looking to learn about resources, just any healthcare things that you run across that you see ads for, that you see the Shriners a lot in community parades and things. But whenever you're thinking about what does this agency do and what's their mission and stuff. Check into that, because there's a lot of really great services that you can learn about. Okay, so usually a child who has, as I said, muscular dystrophy is going to have that progressive muscle weakness. And so these are the things that generally are going to happen with somebody who has muscular dystrophy. They're probably going to have difficulty walking. We'll talk in a minute about when that actually happens for most kids. And probably at some point are going to require a wheelchair. So when I started being an OT, it was very common, and part of my training was in doing seating and positioning. Now you guys are going to get some of that in your program, but now in the last few years they've passed a requirement that you actually have to be a certified seating specialist. And so usually the way this will look, if you're not a certified seating specialist, you're probably going to call somebody from a wheelchair management company, somebody who sells wheelchairs and can prescribe wheelchairs for people, somebody who is a seating specialist, and you're going to work together. So as the OTA, your job would be to say, here are the difficulties this person is having. This person, can move their arm in this certain way, can move their head in this certain way, can only move their head, not the rest of their body, or whatever the situation is. And then you're going to be working with that wheelchair expert to be coming up with all the different components of the wheelchair that are going to be important for that person. And so together you go through the footrest, you go through the seating, you go through the back, you go through how it's powered, and all of those different things. How much lateral support on your sides you need, where will the arms go, what do the arms come off, do they swing away, the footrest, do they come off, do they swing away, are they static? So you're going to be talking through all of those different parts and basically constructing a wheelchair that will be made and ordered for that person. So that's what will happen if you're not certified. If you are interested in doing that, that's a certification that you could take later on in your profession, is that you could become a certified seating specialist. So that's something for you to think about if that's something that interests you. When I have progressive muscle weakness, the other problem I might have is contractures, which contractures are a shortening of the muscles or tendons around the joint. So back when we talked about CVA, we talked about spasticity and flaccidity. Now let's go through those again just to remind you. So flaccidity means the person has zero active motion, right? Spasticity means that they're getting too much motor recruitment in those muscles, and when they pull up into flexion, they're actually being stuck in that position. However, with spasticity, they're pulling up into a flexion pattern, but how I know it's spasticity is if I try to pull that into passive range of motion, I feel some resistance. But the key to it is I can pull it in passive range of motion. The difference between spasticity and a contracture. So if we talk about flaccidity, that person's arm is going to feel really heavy. They're not going to be able to help me move it at all. And when I try to move it, I'm actually going to have hypermobility of the joints. If I have spasticity, I'm not going to be able to maybe get them into a full stretch. It's going to be hard, but I can pull them into full extension generally, unless they have really severe spasticity. The other word we used was synergy. Now a synergy pattern means that I am going to pull up into that flexion pattern, but if I went to do passive range of motion on that person, they have no resistance to that motion. Okay, so when they are walking, they might be up into a pulled flexion pattern in the flexion synergy, but when I go to take them into passive range of motion, there's no resistance to it. A spastic arm also pulls up into flexor synergy, so into that pattern, but when I do passive range of motion, there is resistance. So I've got flaccidity, spasticity, synergy. Okay, synergy causes me to pull up into this flexion pattern. Then if I have weakness, I can't really get myself out of that pattern. What will happen is if nobody does passive range of motion on me for a long time, then I'm going to get shortening of my muscles and tendons around that joint, and that's what's called a contracture. What happens when that happens, and there may actually, if it's been long enough, be bony growth around that site, to the point at which I won't be able to move them out of that position anymore. And in order to move them, I would have to break their arm or have surgery to cut the tendons. So that's something we want to avoid this at all costs. You see this a lot with patients that might be at a nursing home and just not getting good care, or maybe they've been left alone at home after a stroke and they don't get good care. So that could happen. The same can happen with somebody with muscular dystrophy. If they're not getting constant stretching and getting that lengthening of those muscles and those tendons, then they're at risk for contracture. And then I have to do something to fix that problem. One of the things we might do, if stretching isn't enough, we might include some splinting, or we might include some casting to help kind of an elongated stretch, meaning over a long period of time we stretch just a little bit. It helps to, whenever we'll talk about this later in the program, but whenever you are stretching yourself, the literature is pretty clear that 90 to 120 seconds of holding a stretch is actually better than most of us stretch for 10 seconds and then we move on to the next motion. But 90 to 120 seconds is actually a better stretch for you. We'll give it time to really do a full stretch, so that's what we want to kind of go for. People with MD will also have breathing problems because the progressive weakness also affects the muscles that help them with breathing. And eventually some of these people will need a ventilator at night or in the daytime because of that. Also, we see the weakened muscles in the back may not be able to hold the spine straight, so we see some scoliosis. Scoliosis is something that can be fixed with braces. I have a friend whose child actually goes to the Shriners Hospital in Utah, and she has a disease similar to muscular dystrophy that causes her to have scoliosis, and so she frequently has rods put in her back and a lot of different braces and stuff to keep her spine straight and to help straighten her spine from those weakened muscles. The difficulty is that because you have that progressive weakness, that's always going to continue to get worse, and so it's really just a management thing, a constant management of the scoliosis. And I would say that, I've had patients who have had scoliosis even as an adult who might later get surgery for their scoliosis. However, the one thing about this is because it is a progressive muscle weakness, even if you fix the scoliosis with surgery, you're still likely to still see some of that in the future. So it's really a medical management issue. A lot of people with MD also have heart problems. You're going to see that on the list here in a little bit because the muscular dystrophy, again, causes weakness, and the heart is a muscle, so it reduces the efficiency of that heart muscle. The same with swallowing. We know when we have swallowing problems, it's called dysphagia, right? If the muscles are affected, then I'm going to have that. I could have dysarthria, which is the muscles of the mouth. But if I'm having trouble swallowing, then of course I'm having trouble taking in food, and also aspiration pneumonia can develop. So remember that aspiration means that I'm taking my food into my lungs instead of through my esophagus. And so sometimes my muscles are weak that help me to cough, and so I can't get that food back up out of there, and so it does cause pneumonia. And remember, silent aspiration means that I'm doing that and I'm not even coughing. So you can imagine how bad it feels when you accidentally swallow something into your trachea and your body is forcefully trying to remove it from your system. And imagine that, and then imagine that that you're taking it in, but you don't even try to get it back up. And you can imagine how, that's pretty traumatic when that happens. It hurts even, it's painful. So you can imagine that there must be quite a bit of weakness for that to happen and you not to cough it back up. But that's a very dangerous thing. So we're looking for things like low-grade fever, which will help to identify that aspiration. And so some people may have to have feeding tubes, and definitely probably some kind of swallow study. Video fluoroscopy is going to be done so we can determine what levels of liquids do they need to be thickened, and do we need to have different consistencies of food or things that we need to avoid. Maybe they need pureed food so that they don't aspirate. All right, so in the next couple of slides you have charts here that have the different types of muscular dystrophy on one side. You have the age of onset, clinical features, and then just some other things. So I'm going to just point out through these some differences and things that you want to pay attention to, that you might want to mark on your chart here. So Duchenne's muscular dystrophy is actually the most common type of muscular dystrophy. Half of all muscular dystrophy is this type. And so usually this is something, I want you to look at the onset ages and just kind of lump together the ones that are early on and the ones that maybe go for adulthood. That's how I want you to think of them. You don't have to memorize these exact things, but think more child onset versus later onset. Okay. With Duchenne's, a lot of times you see this walking on toes, waddling. Their calves get really large, and they get that pain and stiffness because their muscle basically is breaking down. It causes scar tissue. This child is usually in a wheelchair fairly early, usually by middle school age. You're also going to see a lot of times this kyphoscoliosis, which you'll see these postures, and you can look up information online. You can look up images of this. You'll see kids that really have to stick their belly out to, they change their trunk posture to accommodate for their walking weakness. And so that's something, and I believe in the video that I showed you, the girl on the video was talking about her posture and things too. You do see cardiomyopathy, so again, disease within that cardiac muscle with this patient. And then you can just look over at some of the other, so a lot of times these kids will have learning disabilities. And an important thing that I was reading about was about survival. So a while back, they weren't really expecting these kids to live really past their 20s. Now there is some evidence that people are living more into their 30s, and there are actually men with Duchenne's that have lived into their 50s and 60s. So it's not totally uncommon for that to happen, but I think 20 to 30 is probably a fairly common life expectancy. And I think this is an important piece here because, you know, I think just as our support for families go, not that that is your focus, but I think, you know, being just really trying to help people understand the life expectancy and the progression of this disease is important. I think it's also important when you're talking about progression with people that you don't know what their progression is going to be, so you can't ever say, you know, you're going to live only till you're 20. You don't know that for sure. But I think just providing them with information is important, and they'll take from it what they need to. Usually boys have Duchenne's. You can connect Duchenne's with Becker, which is the next type here. Becker is really just a more mild and a slower progressing form of Duchenne's. So that's a clinical feature that you really want to pay attention to. If we look down at the Emery-Dreifuss, this is again pretty early. The difference with Becker, between Becker and Duchenne, is that Becker is usually diagnosed a little bit later on, and so if you kind of remember that it's a slower, more slowly progressing type of MD, then that'll help you to remember the difference between those two. Emery-Dreifuss is more of an early childhood kind of disease, and in this one there is no intellectual effect at all. But there is one of the problems that you see often in this type of MD is that they have cardiac conduction blocks. Basically, one of the first signs a lot of times for this that you know there's even a problem is people will faint often, and nobody knows why, and then they can go in. So it has to do with this cardiac conduction block where the conduction it stops, and so they're not getting that, they're getting that syncope situation. So also with this one, elbow, neck, and heel contractures are really common. So that's going to limit their ability to do ADLs. It's going to limit their ability to, you know, look around, and it could limit their ability to run a wheelchair. even. So one thing to bring up if you're not familiar with wheelchairs is that wheelchairs can be run all different kinds of ways. So we have manual powered wheelchairs that are powered with the arms. We have power wheelchairs which could be guided a lot of different ways. There could be a joystick that somebody uses. There are also what are called sip and puff wheelchairs. If you look online for MD, there's a lady, her son had a type of neuromuscular disease, and she has a sip and puff where she is taking puffs from her ventilator actually the whole time that she's speaking. But basically a sip and puff is you can set the control, so if you sip or you puff, it helps you to go forward or backward or turn the wheelchair, so there's different controls that way. There's also head controls on wheelchairs that you can use. And so part of, even though you might not be prescribing the wheelchair to the person, what I have experienced in OT is that what you're doing is you're trying to teach them how to use it. And so you're taking them into their functional situations and trying to teach them how to use the wheelchairs that they have gotten, because sometimes that's the part that is most difficult in my experience with them. Limb girdle type is early childhood, usually up through adult, slower progression, but it's just what it sounds like. The weakness in the limbs, weakness in the pelvic girdle, the hip, and so when this person is frequently tripping a lot of times because they're not able to dorsiflex their foot. So this person is going to be one wearing a brace on their foot, so it helps to clear their foot every time they swing. Every time their gait progresses forward, they're swinging their foot so that they can not trip over the curb or drag their toe on the ground. So that's the limb girdle. All right, so then we have congenital. Congenital is defined or is unique because it happens at birth and usually before age 2. So this is really the earliest onset. This really varies, though. The issue with this one is you don't know if it's going to be slow and non-progressive or if it's going to be rapid and very progressive. Obviously, if it's rapid and very progressive, it reduces their lifespan. Largely, a lot of the lifespan is affected because of the respiratory failure, because of the weakness of the breathing muscles. This person can have hypertonia or hypotonia, so low tone or high tone. And again, we would say flaccidity for hypotonia, spasticity for hypertonia. The person is, because of that, is really at risk for contractures. And because this happens at birth, this person may have more delayed milestones than maybe somebody with Duchenne's, because somebody with a later onset is going to have a lot of time to develop and explore their environment and be able to develop fine motor skills and gross motor skills and vision and all of those things. Whereas a child who has this from birth is always has been dealing with this progressive weakness and other things. So it will delay. It's going to change the type of play that they do. It's going to change, and you guys are learning that in your 150 class. It's going to change the way that they can meet those milestones, cutting and handwriting and bouncing a ball and standing on one foot and all of those things. They may not experience that in the same way. You might want to mark on this one that eye defects. That's something unique about this one. Eye defects, seizures, and learning disabilities are really common. And again, if you just really think about learning disabilities would be common because from the time I'm born, I'm having an issue with these muscle weakness. And remember too, with eye defects, that our eyes have many muscles that work with them, and so when I have weakness in my body, I not only have weakness in my body, but I have it in my eye muscles too, which can cause a lot of oculomotor issues like double vision, for instance, if your eye muscles are weak, and just being able to focus between near and far vision, accommodation type of things. So those are issues that person may have. And as well as sometimes with MD, there's issues with retinal issues and things like that. So the next one is the fascioscapulohumeral. It's a big word, which just sounds like what it is. It has to do with the face, the shoulder girdle, and the humerus. And a lot of times with this one also you have lower leg progression. So this is kind of an interesting one because it can be really early or it can be really much later than normal. Normally, they see the muscle weakness first in their face and their shoulders. When I have those weak abdominal muscles, I start to get too much curvature in my back, my lower back, which is called lordosis. The other thing that's really common in this is you see the weakness in the scapula muscles, and so what happens is the scapula wings out. And if you search scapular winging on Google, you're going to see some good pictures of that. But scapular winging happens because the muscles that are underneath the scapula become weak, and so they don't hold the scapula to the rib cage. And so instead what it does is it wings out away from the rib cage, and the muscles are all pulling in a different way, so it's not holding the scapula stable, which also means when my scapula isn't stable, I don't have the same kind of range of motion in my shoulder. So those are things. Most normally a normal lifespan, not really any cardiac issues, so lots of that weakness, but not really the more systemic kind of things. What is common in this is retinal issues and mild hearing loss. So because you're having weakness in this part of your body specifically. Okay, oculopharyngeal, again, just what it sounds, eyes and swallowing. So you can remember that. This is actually well, it's not the most common, but it's largely between 40 and 60 years old. And people first notice this a lot because their eyelids get droopy. That isn't the only reason that causes droopy eyelids, but ptosis is the name of that. So make sure you've gotten that in your chart of terms that you need to know. Here again, dysphagia, again, and breathy voice. Often with that respiratory issue, you're going to have a lot of that breathing, breathy voice as well. But that's where the focus of that is really more up here in this part of the body, and you don't see as much. It is not uncommon for them to have more limb involvement later, but it's not the focus usually in the beginning. And then the most common form of the adult onset, which would be something for you to note, is the myotonic type of MD. So this is where, again, it's face, it's shoulder girdle, and it's foot, again, that foot dorsiflexion. Myotonic is kind of an interesting MD because what happens with this is that they have an inability to relax their muscles after those muscles contract. And so if I went to shake their hand, they've got to contract their muscles to be able to do that, but then they have a hard time pulling back from that because they can't relax enough to do that. It's also known as Steinert's disease, which was just a person that it was named after. This person does have heart rhythm issues, mental impairments, cataracts are not uncommon, gallstones. This because, again, here's a systemic issue, weakness in muscles of digestion, muscles of the uterus. So a lot of times there are, because it is adult onset, people may have children even before this, and so in pregnancy this can cause issues because of the muscle weakness, but it is a very slow progressing. So you can see there's a lot of differences, but there are a lot of similarities. Try to, when you're looking at this chart, pick out the things that make each one of these things unique. That's how I'm testing it when I'm looking at it. All right, so we're going to talk about some of the difficulties that people experience. These are not going to be, they're going to seem like common sense to you, I think, when you look at them. So we know that people, we talked about this before, in areas of eating and feeding, dysphagia, aspiration, in dressing. Okay, so this information that I'm about to give you came from a study. There's not a lot of studies, but there was a study that I found from occupational therapy that kind of looked at people who specifically had myotonic muscular dystrophy, and they said 15% experienced problems, needed assistance or adaptive aids for dressing. This is, again, myotonic. All right. In the area of activities of daily living and bathing, a little more difficulty with that overall. And also with toileting, again, needing assistance, adaptive aids. And again, not a big surprise because it's all related to muscle weakness. Okay, you don't have to memorize these percentages. I'm just wanting you to kind of see some of the problems people are having. So in household tasks, people are not doing the tasks. Some people are doing it but they're just having trouble maintaining it. So factors that predicted the disruption of the participation: what their lower extremity strength was, how much fatigue they were having, how much support did they have from other people, what's the attitude of the people around them. I think that's an important piece. How much education they have. Did they understand their disease? Were they managing it correctly? And income is always tied into that, that the less income I have, the less resources I have, the less education I may have. Not necessarily, but sometimes I might have not as much support from the community because I don't have the resources to get out and be involved in the community, or find help if I need help, and difficulty with meal preparation. So when you're looking at these, really important things that I want you to look at are what are the factors that would influence their difficulty doing these things. The most affected area of daily activities is general mobility. So that's a key. Anytime you see in your notes something where it says this is the most affected, or this is the biggest change for this, or this is the biggest influence, those are definitely test question things you want to look at. So a lot of people, one study they had reported among 51 patients, only 6% reported using a wheelchair, though there are other studies. It's really an area that we need to do a lot more studies, because definitely there are people out there that these studies are not applying to. Some patients have early and severe involvement of knee extensors, so they're falling early. More than 50% of the people who had myotonic muscular dystrophy were still driving. Again, so muscle differences in muscle tone, hypersomnolence. The people are having trouble because they're falling asleep in times they shouldn't be falling asleep. They also have decreased cognitive functions, decreased grip strength, which affects their ability to drive. Okay. Again, in myotonic studies, 12 to 31% of these people held a job. A lot of them used to work and aren't able to work because of their progressive muscle weakness. So again, factors: muscle impairment, low education, because again, if I can't access the education, then that's why online for a lot of people who have MD is really important. Whether it's, and also I don't know if you're familiar with, there's a lot of online platforms now called MOOCs, and I actually am involved in one myself that is kind of a, it's not an academic MOOC specifically, but it's with all of these colleges and different professors just provide free classes, and so I can pick which topics I want to take, and then I can sign up for this free class, and at the end I get a certificate. And they're really great classes. You can choose from all kinds of things about literature, finances, I mean pretty much any topic you can think of. But MOOCs are it's an open resource for people. It's free, and they can find that kind of education. I think is important not only for the type of work that they might be able to do, but also what, maybe just even education about their own disease, the fact that they have access to a computer, they have access to bus transportation to get to a library, to use a computer. All of these things are really important when we're looking at OT, not just, doing exercises or doing ADLs, but also really looking at access to resources. I had a gentleman who was in a power wheelchair one time, and he was telling me it was really great because the bus did pick him up, and the bus does have a wheelchair lift, and that's great. It takes a while to get on there. You guys are going to be taking the bus in a couple semesters. And one of the things that happened to him, though, he needed to go to this company to get some wheelchair parts, and he got off the bus and he started going. Well, then the sidewalk ran out, and he was saying, the only choice he had once the sidewalk ran out was to go back to a place where he could get on the street and then ride the electric wheelchair in the really busy street. And he said he didn't feel safe with that. He didn't think it was a good choice for him. So he basically just got on the bus and just went back home. And I think sometimes we take those things for granted. And so I think looking at access, looking at their ability to be outside of just sitting in their home, they need to have access to the outside world in some way. So I think online platforms are a really great way for them to do that. Online education at OTC, for instance, for somebody with MD might be, if they have computer resources, they could take classes at OTC, they could get a job that they could work from their wheelchair or work from home. So these are important things for them. Daytime sleepiness, again, we talked about that. It kind of limits you when you're trying to work. Need for technology or inability to use the technology. So they have a computer, they just don't know how to use it. Those are things you can train people in OT if that's what they're having trouble with. Lower extremity strength, and then of course fatigue and pain. If I'm tired and I hurt all the time, it's going to be really hard for me to focus on my work. Play and leisure, same kinds of things. Again, lack of money, being able to go do things. So helping them to find resources that relate to free things that they could do in Springfield. That would be a great treatment for them. Again, fatigue, distance to my play and leisure activities. Maybe there's things I could do in my home. Maybe there's things I could do online. Maybe there's, how could I open up their world without them having to travel somewhere. The activities they love, but they're not adapted to their condition, so we could help them learn to adapt their play and leisure activities for their condition and for their situation. If you did Day at the Lake is one of those experiences at the Southwest Center for Independent Living where they allow people who have disabilities to participate in outdoor events. They also have a day at the range in the spring where they take people out and they do things like shoot guns, and I think they fish and different kinds of outdoor things and help them adapt them for the wheelchair. So that's really great. Maybe they need assistance and they don't have it. The gentleman, I put out an announcement this week about somebody, a student at OTC, he doesn't drive, and so he needs assistance to go to his, he likes to go to the Y and work out, so he needs it to drive there, and he needs to get to social events and things. He needs somebody to assist him with that. Because he doesn't have transportation, and so we might teach him to use the bus, or we might, help him find different resources that give him rides or things like that. So as with progressive disorders, one of the main keys is that we're not doing interventions to restore function all the time. Sometimes we can restore a little bit of function, a little bit of strength if we don't overdo it, but a lot of times we're just trying to help them maintain at the level where they're at for as long as they possibly can. So it's super important with this patient that you prioritize the treatment by talking to them, finding out what they want to do, what they need to do, what they're expected to do in their life, and really plan everything around that instead of you coming in with a preconceived notion, okay, we're going to do this exercise, we're going to do this. You don't want to take for granted that you know what's important to them, and because it is a progressive thing, they need to be able to really identify what's important to them and what they need to be able to do. So, because again, there's very few studies in occupational therapy on MD, it's really based on clinical practice and what you're seeing with your particular patient. So you want to make sure you're doing a really good interview. You want to use a client-centered approach, determine what they need to do, and what are their problems that they're having. Educate the person about their disease and talk about adaptive strategies. Here's some equipment we can use. Sometimes equipment is not the answer for everybody. I think that's an important piece, because sometimes we say, oh, we've got this great dressing stick. Well, just because we have the dressing stick doesn't mean that it's going to work for people. I think stroke patients are a perfect example of that. We have all this equipment, we think, but really having them do it normally with just a different technique is actually usually better for them. If somebody has a lot of cognitive problems, you're not going to hand them 14 pieces of equipment that they can't understand how to use. So also, when you're thinking of deciding how to do interventions with your patient, start normally first. Do it the way people normally would do it. Then, if that doesn't work, see if you can just give them a few cues, some instruction, and maybe that'll help. If that doesn't work, then you go to more of a, think of a different technique, but don't include equipment yet. Just try to think of a different technique that they could use. Hemi dressing. I don't know if you've had that yet, but hemi dressing for somebody with a stroke. So teaching them certain ways to put their arms and their head in the shirt can be just really effective, and you don't need equipment. Your last ditch effort to me is the adaptive equipment, because adaptive equipment costs money. most of these people don't have money. Most of your patients in general don't have money to spend on adaptive equipment. So most adaptive equipment is not covered in Medicare or insurance. It's all private pay. So most of us don't have a lot of money to put towards stuff. We're only going to buy the stuff that's really necessary. So that's one of the reasons. The other reason is because it's difficult. You know, if you have a specific spoon that you use to eat and you want to go out to eat, that means you always have to have your spoon with you, which you're not always going to do. And sometimes it's the aesthetics of things. They don't like the look of it. They don't like the feel of it. They just don't use it. It's like many things in our own home, that it's just clutter around their house. A lot of people are cluttered with adaptive equipment they don't use. So remember, normal, then verbal cues, then technique, then adaptive equipment. A side lecture you get there. Okay, so training and activities of daily living, that's what we're going to work on. We're going to work on some motor skills, maybe fine motor, gross motor skills. We're not going to use a ton of resistance with these things, mostly just active range of motion kind of things. Assistive devices if necessary, splints or slings if necessary, but we want to really be careful about using slings for patients too long, because then they get stiff and they could get contractured in these positions. So lots of good stretching if you're using splints. Energy conservation strategies, which you'll learn about as you go through the program. Educating patients and families on all of this information, really important, connecting with them. Some kind of braces, so for those patients that are having trouble keeping their foot up, so if they are toe dropping and dragging it on the ground, you're going to want some kind of ankle foot orthosis, to keep the Achilles tendon really stretched out. They might be in a standing walker or a standing frame, because we want them weight bearing. We want them to have increased circulation that gives them healthier bones, straightens their spine, also just changes their whole perspective and gives them a view of the world that's different and allows them to interact. Like this little girl with the horse, it puts her at eye level with the horse instead of down here below the horse. She's able to stand up, and there's just something about that feeling of independence, I think, when you're standing. So those are things you might do. Wheelchair mobility, we talked about that already a little bit. So either practicing the mobility with them or helping them to get a wheelchair. In strengthening and stretching, there was this one study that said a hand training program, if the person has at least 3 of 5 muscle tests. And what that means is a 3 of 5, which we'll learn next semester. A 3 of 5 means that you're doing full range of motion with your wrist or your hand. So you have full range of motion, but you can't take any resistance. So if I were to try to put resistance on your hand, you wouldn't be able to hold it. Okay, that's a 3 of 5. So for 12 weeks, 3 times a week, 45 minutes each, there was some putty and stretching program that these people did, and they said there was some efficacy of that. So, but be careful not to overdo it. Aquatic therapy is a really great choice for people for exercise, and I put a video for you on here so that you can see the aquatic therapy. And I think there's several sites that we have for clinical that do have aquatic therapy. There is a site in St. Louis that does strictly aquatic therapy, so that's something to think about if you're interested for clinical. But aquatic therapy, I think, can be really valuable to people because it's low resistance and they can still get that good workout. Now, with feeding and eating, making sure you know what their strategies are. You're probably going to be working with the speech therapist to see if they're clearing every time. Are they getting rid of that food in the right way? You might have them doing repeated swallows, so swallowing over and over again to make sure the food gets down. Chewing very slowly and getting that bolus, which is that kind of lump of food in your mouth, to a liquid consistency before you take it down, instead of trying to swallow big chunks of things. Making sure the thin and thick consistencies are what the person needs based on the video swallow studies. And then looking at really their psychosocial, what are their relationships, who do they have in their life, what kind of community activities are they doing. We really want to make sure these patients aren't getting socially isolated. That's a really it really will impact their function as it would for any of us. There are some studies that show that belonging to community associations has improved the well-being of these patients. So whether it's MDA association or some other kind of association where they can feel connected, I think, to other people maybe who are struggling with the same thing, a peer support group maybe through NAMI or through the hospital or through the MDA, that's something that might be really valuable to people. There's a lot of resources out there. I've used for this PowerPoint Mayo Clinic MDA, and then there's a great Myotonic Dystrophy Foundation toolkit that's where a lot of the study resources came from. So overall, just remember progressive muscle weakness, probably some cardiac issues, a lot of times early onset, mobility is the biggest problem, you know, and really just helping people to get back to their function in the way that is important for them to live out their life. So I hope you have a great week. If you have any questions, post on Ask the Class, and I will see you very soon. All right?